Hello, future nurses and science students. My name is Mr. Spleen, and I am the ultimate purple fist-sized guardian of your cardiovascular and immune systems. I am a soft, highly vascular crescent-shaped organ weighing about 6 ounces. I sit quietly tucked away in the upper left quadrant, ULQ, of your abdominal cavity, resting safely right between the bottom of your stomach, your left kidney, and the lower edge of your left rib cage. In your advanced medical surgical courses, you will hear my structures, surgeries, and enlargement described using the root words spleno or leon, like splenomegaly, splenectomy, or splenic infarction. If you see those terms, it's all about me. While you can technically survive without me, my daily double duty mission is vital. I act as the ultimate cellular graveyard and recycling center for old red blood cells and a massive homeland security checkpoint where white blood cells screen your blood for systemic infections. The internal layout, red pulp versus white pulp. To understand how I multitask, you must look at my internal microanatomy. If you slice me open, my tissue is divided into two distinct functional zones that you must memorize, the red pulp and the white pulp. 1. The red pulp, the blood recycling plant. The red pulp makes up about 80% of my total mass. It consists of twisted, narrow pathways called splenic cords wrapped around wide blood capillaries called splenic sinusoids. The squeeze test. This is where Ruby the red blood cell faces her ultimate test. As blood moves through the red pulp, red blood cells are forced to squeeze through microscopic slits in the capillary walls. Young, fresh, flexible cells bend easily and pass right through. The graveyard. When a fragile, worn-out red blood cell approaching its 120-day lifespan tries to squeeze through, its rigid membrane breaks open. The cleanup. Waiting right on the other side is an army of Max the macrophages. They swallow the broken pieces, save the highly valuable iron to send back to the bone marrow, and convert the remaining protein waste into bilirubin to be processed by the liver. 2. The white pulp, the immune sentry. The white pulp looks like tiny islands scattered throughout the ocean of red pulp. It consists of clusters of lymphatic tissue wrapped tightly around central arteries. The screening. While the red pulp filters out physical cells, the white pulp filters the blood for biological threats. The army. It is packed to the brim with Luke the lymphocyte, both T and B cells, and macrophages. As blood pumps through my central arteries, these immune cells continuously screen the fluid for circulating bacteria, viruses, or foreign toxins. If they spot an antigen, the B cells rapidly activate into plasma factories and flood the bloodstream with neutralizing antibodies. The major functions of the spleen. For your comprehensive nursing exams, you can break my daily physiological responsibilities down into 3 key areas: erythrocyte destruction and recycling, immune response activation, and blood reservoir storage. 1. Cell destruction and recycling. As the body's primary blood filter, I remove old, damaged, or abnormally shaped red blood cells like sickle cells, along with worn-out platelets and cellular debris, keeping the bloodstream clean and smooth. 2. Active immune surveillance. Because I am directly connected to the circulatory system, I am highly optimized to catch pathogens that have managed to escape local tissues and enter the bloodstream. I activate adaptive immunity to prevent localized infections from turning into systemic blood infections, sepsis. 3. The emergency blood reservoir. Because my internal sinusoids are incredibly wide and stretchy, I hold on to a backup supply of about 150 to 200 milliliters of concentrated blood and up to 1/3 of your body's total platelets. The action. If your patient experiences an acute injury and begins to hemorrhage, or if they exercise intensely and need extra oxygen, their sympathetic nervous system fires a signal to my smooth muscular capsule. I contract forcefully, squeezing that stored reserve of fresh red blood cells and platelets right back into the general circulation to help maintain blood pressure and oxygen delivery. Common spleen pathologies. When I swell past my boundaries or my delicate outer casing ruptures, it creates an immediate medical or surgical crisis. 1. Splenomegaly, spleen enlargement, an abnormal enlargement of the spleen. Because my tissue is highly flexible, I can swell up to several times my normal size if I am overworked. The causes: most commonly triggered by infectious mononucleosis. The Epstein-Barr virus forces a massive overproduction of lymphocytes that jam my white pulp. Portal hypertension from liver cirrhosis, causing blood to back up and congest my red pulp, or leukemias. The complication, hypersplenism. When I grow too big, I become overly aggressive. Instead of just recycling old cells, I start trapping and destroying perfectly healthy red blood cells, white blood cells, and platelets. This causes your patient's lab values to crash, leading to anemia, leukopenia, and a high risk for bleeding. 2. Splenic rupture, the catastrophic bleeding emergency. Because I am an incredibly soft, sponge-like organ packed with blood, I am wrapped in a very thin, delicate outer fibrous capsule. If a patient experiences blunt trauma to the left upper quadrant, such as from a steering wheel impact during a motor vehicle accident or a sports injury, this thin capsule can easily tear or shatter completely. The crisis: a ruptured spleen will bleed profusely and uncontrollably directly into the peritoneal cavity, rapidly draining the patient's blood volume and leading to fatal hypovolemic shock within minutes, if not rushed to emergency surgery. Image demonstrating a splenic rupture with blood pooling into the peritoneal cavity following abdominal trauma. Critical nursing assessments and implications. The strict palpation rule. This is a major top-tier safety rule for nursing students. On a healthy adult patient, the spleen is small and hidden safely behind the ribs, meaning it is completely non-palpable. If you are performing an abdominal assessment on a patient with known splenomegaly, such as an adolescent with active mononucleosis, do not deeply palpate the left upper quadrant. Pressing firmly on a massively enlarged swollen spleen can easily rupture its thin, fragile capsule, triggering an emergency internal hemorrhage. The post-splenectomy infection risk, OPSI. If a patient's spleen is surgically removed, splenectomy, due to a severe trauma rupture, other organs like the liver and bone marrow will take over the job of recycling red blood cells. However, the patient permanently loses a massive immune checkpoint. The nursing alert. Post-splenectomy patients are at a lifelong extreme risk for developing overwhelming post-splenectomy infection, OPSI, particularly from encapsulated bacteria like Streptococcus pneumonia and Neisseria meningitidis. The intervention. You must educate these patients on the absolute necessity of receiving their scheduled pneumococcal, meningococcal, and Hib vaccines, checking their temperature daily, and seeking immediate emergency medical care for even a mild sore throat or low-grade fever. Monitoring for rupture shock. If you are caring for a trauma patient with a suspected injury to the left upper quadrant, your highest priority is tracking signs of occult internal bleeding. Monitor intensely for Kehr's sign, sharp severe pain felt at the tip of the left shoulder. This occurs because the pooling blood in the abdomen irritates the phrenic nerve under the diaphragm, which shares a nerve pathway with the shoulder. The shock triad: a sudden, steep crash in blood pressure, hypotension, a skyrocketing heart rate, tachycardia, and rapid, shallow breathing, tachypnea. Keep the patient strictly NPO and ensure they have 2 large-bore IV lines ready for rapid fluid and blood resuscitation. Follow us on YouTube, Felix K's Explore for more. Otherwise, like, share, and follow us if you enjoyed the class. Thank you for your support.